the next step, now that we've got these great TAVRs in place, and I don't mean to, I hope I wasn't degrading the TAVRs too much. We've had great results with them, and lots of patients that couldn't be treated with AVR have been treated with TAVR. And I think the intermediate risk is a reasonable place to be with a lot of patients. But until we know about the durability, I think the low risk we're not there yet. So the problem with valves, with valve replacement surgery is you're either going to be on Coumadin with the problems there, or you get a tissue valve. We talked about the increased use of tissue valves and patients at younger ages are getting tissue valves. There are a lot of places in Europe that don't even stock mechanical valves anymore in their hospitals. And so we're seeing similar survivals with the mechanical and tissue valves, increased structural valve deterioration in the tissue valves at younger ages, and patients with higher transvalvular gradients. The reoperation risk is higher the older you are. So if you get your, if you have your tissue valve for 15 years and now you're 80 years old and you need a reoperation, you can't expect a 2% mortality with a reoperation when you're 80. If you've had prior CABG, a lima LAD, congestive heart failure, low EF, calcified aorta, renal insufficiency, all those things have been shown to significantly increase the reoperation risk. So we've talked a little bit about the TAVR efficacy. It's better than medical management with improved survival overall. It's in the high-risk patients. It's shown at least non-inferiority, in some places superiority, and in intermediate risk patients, it's been shown to have non-inferiority in the clinical trials. Based on the relative success of native valve TAVR and the increasing prevalence of biologic valves, increased surgical risk in elderly patients, which are coming to our operating rooms more and more with tissue valve failures, that kind of brought on this concept of using a transcatheter valve-in-valve. It's much less invasive than a reoperation. So experimental studies were done. Technical feasibility was proven with the transapical mitral and aortic transcatheter valve-in-valve in pigs. And then in vitro studies were done to show that there was good hemodynamic performance with various sizes and various types of tissue valves. This study shows the different ages, 65 to 69, 70 to 74, 75 to 80 years old, and the proportion of AVRs getting tissue valves. And this shows if you're at this age during when you get your surgical bioprosthetic valve implanted, your lifetime incidence of reoperation. If you're 50 when you get your tissue valve implanted, your lifetime incidence of a reoperation is about 45%. So clinical experience with valve-in-valve, Wanawasser was the first one to put in a core valve in 2007 that was successful. And after that, there were numerous case reports, and then there were multiple case series and now registries of valve-in-valve. So the procedure took off really quickly before they really knew much about the outcomes. And what we've learned from those registries has been invaluable in making the operation safer. The FDA did approve transcatheter valve-in-valve for core valve and for the SAPIEN XT. So those are the two valves approved by the FDA. What's really important is making sure that we preoperatively evaluate and come up with a treatment plan that's appropriate for the patient. Is that me? Okay. Thank you. Thanks for that comment. So I'm being heckled by my phone. So what's really important is measuring the inner diameter of the valve, but you also want to know the outer structure and the valve leaflet and what you're going to be, how you're going to be compromising the patient's valve. So if you have a tissue valve that's a 19 millimeter tissue valve, the inner diameter is going to be anywhere from 16 to 17 millimeters. and that's really probably a little bit too small to do a valve-in-valve. We also need to know what the inner structure is made of, how flexible it is or not, and whether we're going to be able to see it on x-rays. So we really need to know all about the inner structure of each of the valves. And this just shows what each of these valves look like on a fluoroscopy. And there's actually an app for that. You can open up the Aortic valve-in-valve app, which we all carry around with us when we're doing TAVRs. So the access for deployment, for aortic valve-in-valve, you can go transfemoral. About 95% of them are done transfemoral. Transapical is really nice because you got the valve on a stick instead of the valve on a rope. You can control it much better. And then we have direct aortic, subclavian access, and direct carotid access. Mitral valve-in-valve can be done transapical or transeptal. Transeptal can be done from the femoral vein or the internal jugular. And the tricuspid and pulmonary, we've done some through the femoral and some through the jugular. So the access is much easier for those valves. The type of catheters we have the balloon expandable and the self-expanding. The XT and the core valve are both FDA approved, but we're also using Sapien 3 and Evolut R in certain situations. The Edwards balloon expandable valves can be done transfemoral or transapical, but the self-expanding valves do not have a transapical deployment. The balloon expandable valves actually sit intraannular. The valve tissues are down at the base of the valve, whereas the core valve, the valve tissues are up above the base of the valve. So you can actually set the valve in a supraannular position relative to the previous bioprosthetic valve. And that actually helps with gradients. So this just shows virtual reality of where the valve, what the valve looks like. You can see this core valve is sitting, the valve structure itself is sitting supraannular, so it's not constrained by the annular rigid sewing ring of the valve. And this is what it looks like on on X-ray. When you want to try to plan your landing zone so that the valve doesn't migrate, but that you want to be high enough so that you don't have too much obstruction to the outflow. The Sapien valve, you can see, does sit intraannular, so the leaflets of the Sapien valve are within the sewing ring, so there is a little bit more obstruction to flow. And this just shows several different valve types. I wanted to show this to show the stented valves here and the stented valves that are externally wrapped. The externally wrapped valves are at higher risk for coronary obstruction. So if you're putting in a trifecta valve or a Sorin valve, mitral flow valve to get a bigger orifice area, you have to take into account if the sinuses are small and the coronaries are close, that might not be a good valve-in-valve option later on. Last week we put in 2 core valves in 19 trifecta valves, and both of them had gradients less than 5 millimeters of mercury, so they were good outcomes, but that's very concerning, and it has to be individualized. Coronary obstruction, it can be devastating, it can be rapidly fatal. The risk in TAVR and native valve is about 1%. The risk in valve-in-valve was about 3.5% in the early registries, but most surgeons have multiple series without any coronary obstruction now, mainly because we're looking for it, we know how to measure for it, and I think when we find that patients are at high risk for coronary obstruction, we'll go to a redo operation instead. So the things that put you at high risk for coronary obstruction include, if you're bioprosthetic, structural valve deterioration is aortic stenosis. If you have stentless valves, bicuspid native valves, due to the coronary positions, sometimes they get obstructed. If you have a native root replacement, homographs are at risk. Toronto freestyle valves are very difficult to avoid the coronaries, although we've done several successfully. Supraannular position of the stented bioprosthetic when it was originally implanted, the externally wrapped bioprosthetic valves, low coronary arteries, and small sinuses of Valsalva are all at risk for coronary obstruction. And then high transvalvular gradients are also a problem. The average mean gradient after a TAVR valve is usually single digit. We usually get very good gradients for TAVR valves now. And it is also based on sizing. The average mean gradient after a TAVR valve is between 12 and 17, and there is a high rate of transvalvular gradients over 20. The risk factors for increased gradients include fixed internal diameter of the stented valves, the small-sized bioprosthetic valves, bioprosthetic valves that were placed originally for aortic stenosis, and the intraannular valve-in-valve position. So the balloon expandable valves are at higher risk for high gradients. So this study was done looking at whether the implant was high or low, and they defined it in a certain way for the different valves. But with the core valve, there was a 15% chance of a gradient greater than 20 millimeters of mercury if it was a high implant, and a 34% chance if it was a low implant. And it was even higher in the SAPIEN valves, 18.5% chance of a gradient greater than 20, and 43.5% if it was a low implant. And this just shows how you can put the valve in an intraannular or supraannular position. So redo valve-in-valve versus redo saver versus valve-in-valve. Most of the studies have shown no difference in operative mortality or one-year survival rates. There have been several retrospective studies. There haven't been any randomized trials. There's also in several studies no difference in stroke rates. We typically don't pre-balloon dilate these valves because we don't want to knock the leaflet out into the brain. Pacemaker rates are very low. The coronary obstruction rates in the later trials have been 0 in most studies, and no difference in high gradients between the surgically implanted redo valves and the TAVR valves in this meta-analysis that was done. In conclusion, the redo surgical AVR is the treatment of choice for structural valve deterioration of a bioprosthetic valve. Valve-in-valve can be considered in elderly or other patients at otherwise high risk for the redo operation, but it is not the operation of choice at this time. So a lot of cardiologists are telling our patients, and a lot of, not just picking on the cardiologists, but a lot of people who know about TAVRs are telling the patients, just get a tissue valve, you'll get a valve-in-valve later, everything will be fine. It's not actually the case. Most of them go really well, but they can be very complicated and they take a lot of planning. The careful pre-op planning is critical. You have to plan for the future when placing your surgical valve. I had a patient who was about 340 pounds. He had had a tissue valve 13 years ago, and he came in, he had a 27 millimeter, I think it was a mosaic valve, and it finally failed after 13 years. And when I looked at his operative note, Dr. Ott next door at Texas Heart Institute had enlarged his annulus to put a 27 valve in, which I was very thankful for because we could put a beautiful core valve in him and he had no gradient and everything was great. But if he had a 23 valve, we probably would have ended up with patient prosthesis mismatch. So you want to avoid valve-in-valve when the patient's at high risk for coronary obstruction or high post-op gradients. And you also want to be sure that the patient doesn't have patient prosthesis mismatch. If they come in and you think if they have high gradients, you have to look back and see if their gradients have been high from the time the valve was put in. Opening up a valve inside that valve won't do you any good.